Thank you, Dr. Kane, for giving us this insight into the education of the human resource and preparation. I now call upon Dr. Beti Thompson, who was the full member of Fred Hutchinson Cancer Research Center, Professor of Health Services, University of Washington, Seattle. And by now we have learned about the QA/QC of the infrastructure. We have got some insight into how to prepare the human resource with educational material. But this needs to be rooted in the soil, the society that is going to be served by these two processes. And it is vital that we are sentient to the needs of this society and the patients that we're going to look after. And Dr. Thompson is going to give us insight into that.
Good morning, everyone. I want to thank the committee for inviting me to this presentation, to do this presentation. I've learned a great deal in the last couple of days about breast cancer internationally and the achievements that we're making as well as the challenges that are left. One of the things that I haven't heard a lot about in this conference is what people think. And when I say people, I mean constituents, everything from women to breast cancer, people with breast cancer, to breast cancer survivors, to decision makers. All of these constituents are very important. It's important to know what they think in order to go on with taking more steps to prevent and to cure breast cancer. So what I want to do today is spend a little bit of time talking about a different kind of metric, I think, for looking at and understanding what people think about breast cancer, all the way from women themselves to decision makers. And I've entitled my talk, Using Social Science in Program Planning, Developing and Designing Studies. And this is a much more micro-level talk than we have heard up to now. In terms of the outline of my talk, I want to accomplish 4 things. First, define and describe qualitative research. I want to basically talk about 2 methods of qualitative research. Then I want to provide some examples of qualitative research around breast cancer and show how those examples can lead to hypothesis generation, the kind of pilot studies that Ben was talking about earlier today, study designs, and program development. So first of all, let me introduce qualitative research. And this definition is probably as good as any. It's a process of inquiry to understand a human issue or problem where the researcher builds, and this is important, a complex, holistic picture from words, descriptions, and views of informants, all done in a natural setting. So qualitative data is quite different from quantitative data. Qualitative data, or qualitative researchers, rely on a few cases, usually in the 10s or 20s, but on many variables. Their idea and purpose is to obtain a deep understanding of an issue or a phenomenon. So large amounts of data are collected that require careful sorting and then reduction. And that process sounds like it may be simple, but it's actually a very complicated process. But what you end up with is a story that you tell from a participant's point of view. Again, whether that's a woman, somebody with breast cancer, or a decision maker trying to understand why they will or will not address barriers or enhance facilitators to breast cancer prevention. So today I'm going to focus on 2 methods. First of all, the first method is elicitation interviews. And these are basically one-on-one interviews that are designed to elicit information from a person, a particular person. A facilitator probes for beliefs and attitudes of the interviewee, and the facilitator remains neutral. That is, he or she does not tell the interviewee what the right answers are. Focus groups, which I'm sure most of you have heard of, are a little bit different. These are held with small groups of people, and group interaction provides information and insight. The group discussion leads to common understanding, and you can identify meanings behind various constructs that are mentioned by the group. So for my example, I want to talk about Latina breast cancer in the Yakima Valley. The Yakima Valley is a part of Washington state that is heavily populated by Hispanics. Over 60% of the valley is of Hispanic origin. And even more importantly, most of these are of low socioeconomic status. And what we wanted to do in our breast cancer qualitative research was to explore the psychosocial experiences, communication, behavior, and treatment decision-making processes of Hispanic women after breast cancer diagnosis. Our rationale was that whatever we found out would help us direct programs, for example, a patient navigator program, to facilitate timely and informed cancer treatment and post-treatment among breast cancer survivors. So the methods that we used, first of all, we recruited participants from cancer survivor cancer survivor groups in the Yakima Valley. These are support groups where people go and talk about some of the problems that they have faced in their breast cancer diagnosis. We did 15 one-on-one interviews. We audio taped all of the interviews and then transcribed all of those interviews. Staff members independently coded keywords and common themes, and staff members and the facilitator met to review the common themes. Again, this sounds easy, but it took a couple of months in order to do the analysis. From those 15 interviews, we identified 24 substantive sub-themes. We collapsed those sub-themes into 3 overarching themes that I'm going to talk about. And we used those 3 overarching themes to make recommendations for 1, hypothesis testing, 2, a study design, and 3, a program development. So here's one of our breast cancer survivors who said, "I didn't think there was anything wrong with me. I was very upset when they told me I had a lump and it was cancerous because I never thought it would be me." And this was a common comment that we heard, that people didn't expect to have breast cancer. So when we looked at some of the overarching themes, we looked at psychosocial responses. One of the things we found was a great deal of fear. Here is a quote from one of the participants. "When they told me I needed surgery, it was terrible for me. When they told me you have cancer, I thought that I was dead." Another participant talked about the support of family and friends. "Now with my disease, it has brought everyone closer. I think I had enough support from everyone, especially my family. That was something that gave me a lot of strength to get through everything." So from those 2 comments, we generated 2 hypotheses that we then subsequently went on and tested. The first one was that fatalism, the idea that cancer is death, is related to delays in seeking treatment for breast cancer among Latinas. And we, in fact, have somebody who is currently examining that hypothesis and finding some support for it. The second hypothesis is that Latinas with social support from family and friends will have better breast cancer outcomes than those without such support. And we have a doctoral student right now who is investigating that hypothesis. So you can see that going from the grassroots, the bottom up,